Steve Banerjee, epidemiologist, biostatistician, faculty member. And in this segment, I'm going to be going over a poster that was presented at the American Public Health Association in November. Um, this is about the synergistic effect of diabetes and anxiety on overall mortality. And first of all, I want to thank my collaborators that have worked on this. This is a multidisciplinary um, type of collaboration. And I think that this is very rewarding in the experience and in explaining to students and other colleagues about bridging the gap between physical health and mental health. So let's go ahead and get started. This is a longitudinal sort of analysis that goes into going from 2000, 2007 through 2012, and then follow up through December 31, 2019. This follow up is through the probabilistic matching through the National Death Index. So 2007 through 2012, that's leads to cross-sectional, but then when you add on this component of follow-up, then you have essentially about 9 years of follow-up average. The reason this is so important is because diabetes, of course, is a major cause of morbidity and mortality. A lot of people have this underdiagnosed diabetes as well that people don't know about. Also, mental health, anxiety is a common problem there. And we kind of saw the anxiety diabetes sort of continuum when the pandemic was taking place in the last couple of years. A lot of people were running out of diabetes supplies, and this caused anxiety in and of itself. But also, people with anxiety may have difficulties in diabetes management, and this is also something of concern. So this study was especially important to kind of tease out all of the different components of bridging the gap between mental health and physical health. Also, because mapping and geospatial analysis is my specialty, I got a master's degree from Johns Hopkins about this. I like to see the distribution, and if you look at looking at 2000, and I'm going to zoom in here so that you can kind of see this. So looking at 2004 to 2021, there has been a rapid increase and rise in the prevalence of diabetes in certain areas, in certain sections of sections of the United States. As you can see, the prevalence has rapidly increased more so in the southern states, but also Appalachia areas that are traditionally impoverished, and especially when a lot of the industries moved from these places, they left behind individuals that were covered through insurance and other things. And so diabetes increased in these areas way more. And you can see kind of also in Arizona, New Mexico, in this area, a lot of diabetes prevalence being increased. So this goes into kind of anxiety disorders as well. This is the most common illness in the US, affecting about 40 million adults, and that's a lot of people. So going into and understanding anxiety is also very important in the context of this study. So if you look at some of the, we added some backgrounds, and if you look at the epidemiological data from the CDC, about 11.6%, which is a high percentage, have either diagnosed or undiagnosed diabetes. And in terms of undiagnosed diabetes, out of this, there are 8.7 million people that are walking around without knowing that they have diabetes. And of course, this diabetes is alarming. This amount is alarming of how many people have undiagnosed diabetes. And then, of course, anxiety can be also directly triggered by diabetes, insulin irregularities and too much insulin, too little, hypoglycemia, low blood sugar. These may also impact anxiety. Diabetes can cause a fluctuations in blood sugar levels, and that triggers the body's stress response and leads to anxiety symptoms. So as you can see, is a multifaceted relationship and interplay between diabetes and anxiety going on. And previously in public health, mental health was not a primary issue to look at, but now all of these different components are being recognized. I know in APHA there was a lot of talks on suicide and a lot of different components of mental health relating to physical health, and that was surprising to me because about 10 years ago this was not something an understudied issue that was going on within the context of this. So that was kind of good. One thing I wanted to focus on, of course, this was in the technology section. So I wanted to go into some of the technological innovations and automated cognitive behavioral therapy, CBT, that can result in improved outcomes for people with diabetes. So diabetes and anxiety depends on, of course, concerns regarding chronic glycemic control, long-term complications, lack of support, self-care burden, and glycemic centered approaches and fear of glycemia. So all of these can lead to anxiety. And so this is something to be focused on and understand. So I'm going to zoom into the next section here and go into the results more thoroughly. So first of all, methods. This was a nationally representative data set where sample weights needed to be used to kind of be able to make sure that this is representative of the United States. I already told you the longitudinal years, 2007 through 2012, with follow-up December 31, 2019. And this linkage was difficult to kind of create because this is not something that is usually found, but a lot of people are not aware of this, but we were, and so we were able to kind of leverage this characteristic of NHANES National Health and Nutrition Examination Survey. So what we looked at was ages 50 years and older. So kind of a middle to advanced age in age adults. So they were included in the study sample, and a tenth had diabetes, tenth of the individual, or 10% had diabetes. So more than a fifth had anxiety in the sample. So this kind of gives you an understanding of the kind of the population level, what is going on and whatnot. National study, and I added some maps here that I created regarding this, that we created. So anxiety affects mortality in diabetic Americans. So the unadjusted hazard ratio for all-cause mortality was 2.08 for those with diabetes versus those without. So diabetes to overall mortality, there's 2 times likely of mortality among diabetics versus if they did not have diabetes. So that's alarming. I mean, of course, it's known that diabetes increases mortality, but to put a value behind it twice as likely is quite difficult. So what we looked at here, and I'm going to just summarize this in a nutshell. Basically, the synergistic effect of diabetes, and then if you look at the moderator variable of anxiety, so the people that had both were more likely to die than people that had either diabetes and anxiety. So the interaction term here is anxiety. So going into that, there's a lot of components that are relevant here. And looking at this map, I think this is a picture speaks 1,000 words. And if you can see the percent of diabetes, there we had looked at 2021. By 2025 here, you can see the South all covered in diabetes, percent diabetes. And of course, the PA is not really Pennsylvania, where I reside, is not very doesn't light up as much. But again, the Appalachia, the coastal regions of the South, this is also the stroke belt and a lot of different things that are going on here. Even Texas is increased in diabetes prevalence. So a lot of this has to do with Medicaid and some of these benefits evaporating due to policy issues. So, in conclusion, of course, I wanted to kind of highlight the technology where people with real-time insulin adjustment can improve diabetes management and reduce anxiety and should be considered. Let me move my cursor here. Our analyses provide vital information on factors that could be helpful for interventions to reduce mortality risk among those with diabetes and anxiety. Given the higher risk of mortality with co-occurring diabetes and anxiety, collaborative health practices should be used to provide widespread screening. So as you can see here, what we did is that looked at poor mental health versus diabetes. And so areas that are kind of gray have more incidence of both co-occurring diseases rather than places that are orange or blue. So there's a lot of gray area. And, of course, the gray area is not all the way to the coastal regions like we saw in diabetes alone. But what was interesting is that Appalachia and southern region, not all the way to Texas, but some of these southern regions, a bit in Atlanta and Georgia, and then going into Louisiana, some of these areas are still impoverished, and that leads to diabetes and anxiety co-occurring diseases. So in summary, you really have to control insulin administration, but also healthcare professionals need to screen for mental health conditions when they're being treated with diabetes. So this is something that falls upon the onus of the individuals, healthcare providers, primary healthcare providers that look into mental health status. There should be a high index of suspicion in that area. Here are the references. I hope this has made some sense. Thank you for listening.